Hello, and welcome to the weekly Neurology Deep Dive. This is where we take complex information, often from recent papers, and really try to extract the key insights for, your day-to-day clinical practice. Today, we're looking at a review from Practical Neurology called IgG4-Related Disease in the Nervous System.
Yeah.
Now, just before we dive in, we have to be really clear. This is purely for educational purposes. No commercial goals here. It's essentially a summary of the information in that paper, and we absolutely recommend you read the full article for all the details.
Exactly right. Our goal today is really to walk you through the main points, the data, the diagnostic criteria, and some practical things to think about for managing immunoglobulin G4-related disease when it shows up neurologically. Let's unpack it.
Great, because this is one of those conditions, isn't it? It can be quite tricky to spot. Might present quite insidiously, perhaps mimicking other things.
Absolutely, and that's why recognition is so vital, because, as the review points out, while neurological involvement itself is pretty rare, especially on its own, it's often very responsive to treatment, so catching it early can genuinely prevent irreversible damage.
Okay, so what exactly is immunoglobulin G4-related disease, or IgG4-RD?
At its core, it's a multi-system inflammatory disorder. It's also fibrotic, meaning there's scarring. And what you see pathologically is tissue being infiltrated by lots of lymphocytes and specifically IgG4-positive plasma cells.
And this can affect various parts of the body, not just the nervous system.
Precisely. It can hit multiple organs, sometimes all at once, sometimes one after the other. That includes the central nervous system and the peripheral nerves.
But the neurological side is our focus today.
Exactly. Even though it's rare, we as neurologists need to be aware of it.
Right. So recognition is key because it's treatable.
Yeah.
What do we know about how common it is? Epidemiology.
Well, the data is still coming together, but a recent U.S. study gave us some numbers. They found a point prevalence of about 5.3 per 100,000 persons. Okay.
And the incidence rate was around 1.4 new cases per 100,000 person years.
So definitely not common, but something you might encounter. Who tends to get it? Age, sex.
It mainly affects middle-aged or older individuals. The typical onset is somewhere between 50 and 60 years old. It's very rare in children. And there's generally a male predominance reported quite widely, although that can shift a bit depending on which organ is involved. For instance, head and neck involvement might actually have a slight female preponderance.
Interesting. Any known modifiable risk factors? Things patients can change?
Really, the only one clearly identified so far is smoking. That's definitely something to discuss with patients.
And I saw a mention in the outline about malignancy risk.
Yes, that's an important point. The review does suggest that people with IgG4-RD seem to have an increased risk of both solid organ cancers and hematological malignancies. Something to keep in mind for long-term follow-up.
Okay. So it presents in varied ways. It's relatively rare. Diagnosis sounds like it could be a real challenge. Is there a single blood test? Unfortunately, no. That's one of the main hurdles. The symptoms are so varied, and there isn't one specific lab marker that's, both sensitive and specific enough.
But what about serum IgG4 levels? That's in the name, after all.
It can be helpful, yes. Elevated levels, the 2011 criteria, used a cutoff over 135 milligrams per deciliter, certainly support the diagnosis, especially alongside clinical signs. Higher levels also tend to correlate with more organs being involved and maybe a higher chance of relapse down the line.
And this seems crucial for us that a normal level doesn't rule it out.
Absolutely critical point. A normal serum IgG4 does not exclude the diagnosis, especially in disease affecting the head and neck, which is relevant for many neurological presentations. Plus, lots of other conditions can cause elevated IgG4, so it's not specific on its own.
Are there any other non-specific lab findings that might be a clue?
You might sometimes see eosinophilia, so high eosinophil counts, or maybe elevated total immunoglobulin E levels. But again, these are just potential clues, not diagnostic.
So if the blood work isn't definitive, where do we go for confirmation?
Histopathology. Getting a tissue biopsy is really considered the gold standard. It's vital not just to confirm IgG4-RD, but also to rule out things that can look similar, like cancer, other types of vasculitis, or even infection.
What are pathologists looking for under the microscope? What are the key features?
There are three main histological hallmarks. First, you see this dense infiltration of the tissue with lymphocytes, mainly T cells, and, of course, those IgG4-positive plasma cells. And actually, the ratio of IgG4-positive cells to all IgG-positive cells is often considered more informative than just the absolute count. The 2011 criteria mentioned needing more than 10 IgG4 positive cells per high power field and a ratio greater than 40%.
Okay, so specific immune cells and their proportion. What's the second feature?
Significant fibrosis or scarring within the affected tissue. And this fibrosis often has a specific pattern called store-form fibrosis. The paper describes it as looking like a woven mat or maybe the spokes of a wheel.
Store-form fibrosis, got it. And the third?
Obliterative phlebitis. This is where you see inflammation within the walls of veins, sometimes dense enough to block them partially or completely.
Now, specifically for nervous system involvement, say, a dural biopsy, are all three of these features always present?
That's a really important point. For neurologists, fibrosis is generally seen, yes, but that classic store-form pattern and the obliterative phlebitis, they're actually noted as being less common in nervous system tissues compared to, say, the pancreas.
Ah, okay.
So the histological picture in neurological cases might be a bit more subtle, which just adds to the diagnostic challenge.
That complexity really highlights why we need clear diagnostic criteria. And these have evolved over time, haven't they?
They have. The comprehensive diagnostic criteria from 2011 were a big step. They classified cases as definite, probable, or possible, using a mix of clinical signs, imaging, serum IgG4, and histology.
And then came the revised comprehensive diagnostic criteria in 2020. What changed?
A couple of key things. One, just having swollen lymph nodes isn't enough anymore for the clinical part. You need more specific organ involvement. And two, those histological features we just discussed, store-form fibrosis and obliterative phlebitis, were explicitly added to the criteria.
And there are even more specific criteria for certain presentations.
That's right. There are organ-specific criteria for things like ophthalmic disease and hypophysitis. And there's also a practical three-step approach from a Creeler that can be useful as a sort of screening tool in the clinic.
Okay, let's get into those specific neurological manifestations. Starting with the eye's immunoglobulin G4-related ophthalmic disease, or IgG4-Related, seems quite common in systemic cases.
It is. The review says over 20%, maybe more than 1 in 5 patients with systemic IgG4-RD have eye involvement. Often presents as what used to be called idiopathic orbital inflammation. Typically people in their 50s, slight male predominance overall.
And if both eyes are involved.
That's a big clue. Over half have bilateral disease, and that strongly predicts systemic involvement elsewhere. The paper cites data showing 80% of bilateral cases had systemic disease versus only about 14% in unilateral cases. So bilateral signs really warrant a systemic workup.
What kind of symptoms should make you think of it? Eyelid swelling?
Eyelid swelling is the most common, reported in about 76%. Then coptosis, bulging eyes in about 45%. You might also see restricted eye movements in a quarter of patients, maybe decreased vision in another quarter, double vision in around 12%, and pain in maybe 15%. Scleritis is much less common, maybe 1%.
How does it look on MRI?
Typically, you'll see these well-defined homogeneous masses in the orbit. They're often isointense on T1, hypointense on T2 images. Sometimes you see bony remodeling, not destruction, but reshaping in maybe 30–35% due to the chronic mass effect. Lacrimal glands, extraocular muscles are often involved, frequently bilaterally. The lateral rectus muscle seems particularly common.
Any nerve involvement visible?
Yes, and this is key. Trigeminal nerve enlargement can occur, and specifically, thickening of the infraorbital nerve branch is considered highly suggestive of IgG4-RD. So features like multiple nerve involvement, that infraorbital nerve thickening, and diffuse muscle enlargement, these help distinguish it from other orbital problems.
Okay, moving deeper into the head. Hypertrophic pachymeningitis, thickening of the dura.
Right. And IgG4-related disease is now recognized as an important cause, maybe accounting for 10–20% of hypertrophic pachymeningitis cases overall. And importantly, it's treatable.
Who typically gets this IgG4-related hypertrophic pachymeningitis, or IgG4-RHP?
Usually older adults, maybe 40s to 70s, and there's a really strong male predominance here, maybe 2 or 3 to 1. Symptom onset can be subacute or chronic. The course varies, could be just one episode, could be progressive, or even relapsing and remitting.
Common symptoms: headache, cranial nerves.
Headache is very common, maybe 40–70%. Cranial nerve palsies are also frequent, around 30–70%. And visual problems like double vision or just impaired sight. The thickening is mostly cranial, over 80% of cases, rather than spinal, which is maybe only 15–20%.
What about CSF analysis?
It's really crucial, mostly to rule out other things like infection or malignancy. In about half of IgG4-RHP cases, you might see a mildly elevated protein level, maybe a lymphocyte pleocytosis. There was a small study mentioned suggesting CSF IgG4 levels above a certain threshold, around 2.27 milli-GDL, might be specific, but we need more data to confirm that.
And imaging, MRI preferred.
MRI gives better detail, especially for the skull base and cranial nerves. You see this nodular or linear dural thickening. Characteristically, it's T2 hypointense dark on T2 images because of the fibrosis. Gadolinium enhancement on T1 images highlights active inflammation, which can help target a biopsy if needed. CT is better for looking at bone changes.
Let's talk pituitary. Immunoglobulin G4-related hypophysitis, or IgG4-RH. Seems like a growing area of recognition.
Definitely. It's now thought to be responsible for maybe 30 to 40% of all hypophysitis cases. Initially, it was mostly described in older men. One report had a striking 9-to-1 male-to-female ratio, average age over 66. But we now know it occurs in younger women too, sometimes even without other systemic signs.
And the symptoms are either hormonal or due to mass effect.
Exactly. You can get hypopituitarism, either isolated hormone deficiencies like hypothyroidism, low libido, amenorrhea, or posterior pituitary issues like diabetes insipidus, which is actually quite common, seen in maybe 42%, or even panhypopituitarism. ADH deficiency seems the most common. Mass effect symptoms include headache in nearly half, visual field cuts like bitemporal hemianopia in about a quarter, and other visual problems in over a third.
So checking pituitary hormones is essential.
Absolutely critical. An MRI typically shows enlargement of the gland, the stalk, or both.
What about the brain parenchyma itself? Direct involvement.
That's much rarer. Usually happens alongside systemic disease, maybe extension from nearby structures. Getting histology from the brain parenchyma itself is uncommon, and the findings can be a bit atypical. The mechanism isn't totally clear, could be vascular, could be infiltration, maybe edema. Cerebral venous sinus thrombosis has also been reported, though rarely.
And clinically, if the brain is involved?
Symptoms really depend on where the lesion is. Could be headache, fatigue, weakness, sensory changes, cognitive issues. Presentation is often acute or subacute. But the good news is these cases generally seem to respond well to glucocorticoids and maintenance therapy.
Lastly, the peripheral nervous system. How does IgG4-RD affect peripheral nerves?
This occurs in a minority of patients. There seem to be two main mechanisms, either direct infiltration by the inflammatory cells causing fibrosis and maybe nerve compression, or, and this is important, through that obliterative phlebitis mechanism we mentioned. The inflammation damages small blood vessels supplying the nerve, leading to ischemic injury and axonal degeneration.
Clinically, what does that look like?
Often an acute or subacute neuropathy. And because of that vascular component, it can really mimic other vasculative neuropathies, things like microscopic polyangiitis or EGPA.
Nerve conduction studies would show?
Typically signs of axonal loss, so reduced amplitudes of the compound muscle action potentials and sensory nerve action potentials. Demyelinating features are uncommon. On biopsy, you see fewer myelinated fibers, lots of axonal degeneration. The inflammation, the IgG4 cells, tend to stay in the outer layers, the epineurium and perineurium, usually not deep inside the endoneurium around the axons. You see fibrosis, and often you can actually see vessel damage, fibrinoid necrosis, confirming that vascular mechanism.
Okay, so we have a better picture of how it presents. Let's shift to treatment. Given the lack of specific trials, what's the general approach?
You're right. There are no big randomized trials just for neurological IgG4-RD. So guidelines are based more on consensus, data from systemic disease, and expert recommendations.
But the core principle is still early diagnosis and treatment.
Absolutely. Prompt treatment is key to maximizing recovery and stopping disability. You generally want a fairly confident diagnosis, ideally with histology, before starting treatment.
And first-line therapy is?
Glucocorticoids, universally recommended first line. Response rates seem pretty good in the nervous system, maybe 90% for orbital disease, high 70s for pachymeningitis, 80% for hypophysitis. Peripheral nerve and brain parenchyma cases also seem to respond well, though data is limited.
Does the steroid dose or duration matter?
It seems so. Higher initial doses and longer treatment courses appear linked to lower relapse rates later on. And sometimes, if there's severe mass effect, surgery might be needed first or alongside steroids.
What about other options for induction, beyond steroids?
Rituximab, the B-cell depleting therapy, looks very promising. Studies suggest it might give a better initial response and, crucially, lower relapse rates compared to steroids alone. The review mentions relapse rates around 19% for IgG4-ARD and 23% for IgG4-RHP after rituximab, compared to maybe 50% with just steroids. So it's definitely an option, especially for severe disease, steroid intolerance, or refractory cases.
Any other alternatives?
Cyclophosphamide can be considered if rituximab isn't suitable or doesn't work.
Okay, so after induction, what about maintenance therapy? Is it usually needed?
It's generally supported by experts, particularly if patients have risk factors for relapse like high initial IgG4 levels, many organs involved, or a history of relapsing before. Relapse is common, unfortunately, especially when tapering or stopping steroids.
How is maintenance usually done? Low-dose steroids.
Low-dose steroids, like 2.5 to 5 milligrams a day, are often used, but long-term steroid toxicity is a major issue, and relapse can still happen.
So are steroid-sparing agents used routinely for maintenance?
There isn't complete agreement on this. Head and neck disease might be tougher to treat and more prone to relapse, perhaps warranting them more often. There isn't enough data to strongly prefer one agent, but things like azathioprine, methotrexate, or mycophenolate mofetil are all considered possibilities.
Looking forward, what are the next steps in research?
We still need a better grasp of the full clinical picture, especially the patterns of neurological presentation. Refining diagnostic criteria and finding better biomarkers, maybe specific immune cell subsets, autoantibodies, cytokines is a major goal. The hope is that better biomarkers might eventually reduce the need for invasive biopsies.
And on the treatment side?
We need more research into why different subtypes respond differently or relapse at different rates. And there's a lot of interest in developing more targeted therapies. Things like Bruton's tyrosine kinase inhibitors, anti-CD19 drugs, anti-SLAMF7 drugs are mentioned as possibilities. But because the disease is rare, collaboration, nationally and internationally, is absolutely essential to make progress.
Okay, let's try to pull it all together. What are the absolute key takeaways for neurologists listening?
I'd say number one. Remember, IgG4-related disease can affect the nervous system, isolated or systemically. Recognize the diverse ways it can show up.
And crucially,
Early recognition and treatment are vital to prevent disability. Don't forget that a normal serum IgG4 does not rule it out, especially in head and neck cases.
histology is key.
It's the gold standard, yes, but be aware the classic features might be less obvious in nerve or meningeal tissue. So clinical suspicion remains paramount.
And treatment.
Steroids first line, usually good initial response, but relapse is common. Rituximab seems more effective for induction in terms of relapse prevention and should be considered, especially in severe or refractory disease. Steroid-sparing agents have a role in maintenance, but it's still an evolving area.
It really is fascinating how one underlying inflammatory process can manifest so differently across the nervous system: eyes, meninges, pituitary, nerves. This deep dive definitely highlights how important it is to keep this diagnosis on your radar because it is treatable.
Absolutely. And it does make you wonder, as we understand the immunology better and get these more targeted therapies, could we eventually reach a point where maybe diagnosis and treatment rely less heavily on needing that invasive biopsy?
That's a really interesting thought to leave our listeners with.
Mm.
Something to definitely mull over. We've covered a lot, but there's more detail in the paper itself.
Definitely. We strongly encourage you to read the full review article.
And that wraps up this deep dive. We hope this has been a useful way to get up to speed on this important topic. Join us next time for another weekly neurology deep dive.